Hello, everyone. Good evening. Can you see me? I hope so. Anyway, I hope everyone had a beautiful day in New York, and I know it's hard for you to come inside, but I think this will really be worth your while. My name is Dina Katz. I am a clinical and preventative cardiologist. I practice up here in beautiful Westchester County in Briarcliff Manor, and I'm really excited to be here moderating tonight's webinar. It's going to be a really interesting one on a very hot topic. We're going to be hearing from Dr. Tapin Bush. Tapin is also a preventative cardiologist. He works out of Sound Shore Hospital on Long Island. He is the clinical cardiac director of the MASLD unit. And if you listen to the entire webinar, you will be an expert in MASLD by the end of this talk today. He's also an assistant professor of cardiology at the Zucker School of Medicine. Tapin is going to talk about the surprising link between your heart and liver health. This is a really exciting hot topic. There's been some recent changes in the nomenclature of this disorder, and even cardiologists and physicians are starting to learn more about this disease and get used to some of the changes. So I am looking forward to this as much as all of you are, I'm sure. Just a few things, a few housekeeping issues. This is a webinar, so we won't be able to hear you, but we really want to hear your questions and comments. So you can put those into the chat box, and I will be checking that, and I'll get those questions out to Tapin by the end of his webinar. So Tapin, take it from here.
Thank you so much, Dr. Katz, for the warm introduction. This is a topic that's very near and dear to my heart, and I want to just start by telling a story. I am very fortunate to be married to someone who is very invested in the Transplant Institute of Northwell Health. She happens to be a transplant psychiatrist, and in her day-to-day activity and workplace, she sees patients who have decompensated at end stage from what we're going to be talking about today. My focus is to prevent anyone from ever needing to see her or the Transplant Institute from here on out. And so it starts with a beautiful, engagement from the community, and I'm privileged to get started. So I am a preventive cardiologist by trade, like Dr. Katz at South Shore University Hospital. And in my few years here, I've seen this disease we're going to talk about really be underdiagnosed, and I want to shed a little bit of light onto it. Again, I'm wearing the hat from the cardiologist perspective. I'm not a hepatologist, so if you could forgive me for not talking about the intricate details, but I'll try my best. So the title of today's topic is the surprising link between your heart and liver health, and what I want to talk about is strictly focused on MASLD, otherwise, and its sister, its sister named MASH. We're going to talk about the definition. We're going to talk about why it's important and why it's so underdiagnosed and how prevalent it is. We're going to discuss how it's connected to heart health. And then finally, we're going to talk a little bit about screening, prevention, and management from the community global health perspective. So let's get right into it. So what is the definition? Well, before we get into what MASLD means, we have to talk about what is steatosis, because the word MASLD, the S in MASLD or in MASH, stands for steatosis. Steatosis is a very fancy way of saying fat. Now, when you think about fat, you think about abdominal visceral fat, but fat can enter any place into our body, any organ system. And what we're talking about today is the number of cells, or the fat cells, that do replace the normal cells in the liver. So steatosis by itself, by pure definition, is if you take a biopsy or you take a piece of tissue from the liver and you take a look at, and maybe that piece of tissue has 100 cells in it. Well, 100 out of 100 cells should be liver tissue. Now, if you replace even just 5% of that, so you're replacing 5 cells, and you're replacing 5 cells with fat globules, well, that's steatosis. And the more steatosis you have, well, the more fat you have in your liver. And that can have huge implications. So what is MASLD? Well, MASLD is a fancy way of saying metabolic dysfunction associated steatotic liver disease. That's a mouthful. Let's break it down. What does that mean? That means you have an umbrella, your liver has fat cells in it, and it's due to secondary causes. It's due to causes, metabolic causes. What are some metabolic causes that we know about? Well, obesity, type 2 diabetes, dyslipidemia, or high cholesterol, high triglycerides. So it means there's a secondary cause, a chronic cause causing fat buildup in the liver. So what is MASH? Well, MASLD leads to MASH. MASH is simply that the fat cells have now started to become angry. They are inflaming in the body. They are causing changes of the liver cells themselves, and they're causing liver damage. So that's where you get hepatitis. Hepatitis is liver inflammation and damage. So you get disease to hepatitis. And so it's very important to keep that in mind. So I want to give a history lesson. And before I get into this slide, the history lesson is very, I think a lot of what we need to know stems from history. So in 1980, a very smart pathologist at Rochester, Minnesota, so at the Mayo Clinic, you may have heard of it. He saw a bunch of liver patients and he took samples from their liver. And what he noticed is that these patients they had cirrhotic livers, but they weren't dying of alcoholism. They had livers that had they had history, zero alcohol intake. And these patients had classic fatty liver infiltration and inflammation leading to cirrhosis. So he termed the coin fatty liver disease or fatty hepatitis. You fast forward, so for 40 years, that definition held true. And it was known as fatty liver disease, aka NAFLD or NASH, non-alcoholic fatty liver disease or non-alcoholic steatotic hepatitis. Well, in 2020, a consortium got together, formed of many organizations, and said, hey, why are we stigmatizing patients and calling it non-alcoholic or fatty liver when it's not really truly related? There's entities out there that are not truly related to obesity. So why don't we just call it something different? So they came up with a term called MASLD, or metabolic associated steatotic liver disease, and MASH, metabolic associated steatohepatitis. So it sounds better. It's like the TV show MASH. So it was something easy to remember. And so in 2024, it was officially adopted as the main nomenclature by 73 organizations and growing across the world. And so now the new terminology has gone from fatty liver disease or NAFLD to MASLD. It's gone from NASH to MASH. And so that is the terminology we're going to be using. It gets even more complicated than that. Well, what if I have fatty liver disease and I was drinking alcohol, but I wasn't drinking a significant amount of alcohol? I was just drinking 1 or 2 glasses here and there. It was very social. It was very rare, or it was a minimal amount per week. Well, you were grouped under the non-alcoholic fatty liver disease patients, or you were grouped with just cirrhosis in general. Well, now we've separated, as you can see by this slide. So you have MASLD, which we've talked about, and now you have a new entity called MASLD. So that's metabolic associated liver disease with increased alcohol intake, more than your 1 to 2 glasses per day, way less than your 14 glasses per week if you're female, or 21 if you're male. So you're drinking a little bit more than just that. So you have increased alcohol intake. And then it even confuse the umbrella even more, which is why we have hepatologists and we have gastroenterologists. Well, now they separated it out even more. So you can have cryptogenic steatotic liver disease. You can have steatotic liver disease due to drug-induced liver injury and monogenetic causes such as Wilson's disease and hemochromatosis. So there's a whole umbrella term of steatotic liver disease, but we're going to focus strictly on MASLD and MASH. So let's talk a little bit about the what we call in the medical world, the pathophysiology, or why does this even happen? So to start simply, it's an excess of calorie intake and insulin resistance. So what does that mean? So not all calorie intake is the same. So you can have healthy calorie intake. So if you talk to, I'll tell you, here's another story. I at one point signed up for a physical fitness trainer. And the trainer told me I can eat as many green leafy vegetables as I want. It will curb my hunger, drink plenty of water, and that will be good for you. That's healthy calorie intake. Well, what if I were to replace all that healthy calorie intake with processed foods, with red meats? Well, that's a completely different calorie intake than the green leafy vegetables. So it makes sense that certain foods have more fat content in it, and you accumulate that more into the organs and into your blood system. Well, what does that cause? That leads to more insulin production. More insulin production causes the liver to work less efficiently, and working less efficiently causes all those bad hormones and chemicals that we have. Mainly, what do we care about in the cardiovascular world? Well, cholesterol. That cholesterol starts accumulating, and that accumulation builds into our liver. Why does it build into our liver? Well, take a look at this very cartoonish figure. How big is the liver? The liver is such a big organ. So where's the processing center? Well, the warehouse in the processing center is in the liver. So it's going to accumulate where it's processed. And so that is the start of the journey. Well, what does that lead to? Well, my body says anytime you're sick, right? Let's draw a parallel. Anytime you're sick, what happens? Well, if you have the common cold, we say drink plenty of fluids, get that vitamin C in, and your body will naturally take over and heal itself. Well, that same thing with the liver, right? So you have all these excess fat cells in your body. Well, what does the body say? Well, I don't like that. Let me start attacking those cells, and all the good cells. Let's start attacking it and creating a shell around it. Well, that leads to inflammation. It leads to a pro-inflammatory process, and that leads to cell injury. Well, it can't eat all those cells, so it leads to cell injury around it. So what does that ultimately lead to? Well, if you have cell injury, you follow with cell death. And cell death is known as fibrosis. That fibrosis is termed, a term of fibrosis is scar. So when you have fibrosis, you get scarring. So what happens? So I had fat globules in my liver. They became inflamed. They started injuring all the cells around them. All the cells around them started becoming scarred out. And now what does that progress to? Well, it's the liver has become very scarred out, and that leads to liver failure, that leads to cirrhosis, and that leads to an entity that a lot of people unfortunately may have loved ones or family members out there, hepatocellular carcinoma. So these are all progression of just a very simple process, which is extra fat cells in the liver. And so I think my words are important, but seeing something is way more important than what I can tell you. And so I want to draw your attention to the picture on the left. It's a bunch of pink cells, but that's if you travel back to 1980 and you take a tissue biopsy, well, you look under a microscope and this is what you see. In the top left corner, which is grade 0, you see normal, healthy liver tissue. It's pink. It's a bunch of little cells that are all clustered together. To the right of that, in the top right, well, that's grade 1. You start to see these white cells, these big globular cells that are infiltrating. That's fat. So you see the neighbors you do not want starting to encroach onto your land. Well, you don't like that at all, but you're still happy because you're the majority. Well, what happens in grade 2 and grade 3? Well, they start to say, "Hey, friends, come over. It's our town now. It's our land. It's our show now." And so everything starts to accumulate, and you can see that there's a very insignificant amount of real or normal liver tissue left. Well, what happens to the right? So you have the right shows you the scale of fibrosis. And so we have 4 different stages of fibrosis that leads to cirrhosis. Well, you can see it's nice and purple. In stage 0, there's no fibrosis. There's some fatty infiltration, which are those small white little globulate cells. And in stage 1, well, now you start to see this purple scarring tissue. It's getting more purple. It's shades of purple, not shades of gray, shades of purple. And so you see these lines, these streaks. Well, that's scar. And then right on the top right next to it, stage 2, significant fibrosis. Well, the cells are getting a little bigger. They're clustering together, and that purple is getting a little darker. Well, that's more fibrosis. Stage 3 and stage 4, a bunch of scar tissue is starting to form, taking over the liver altogether. So that is exactly what's going on in your liver. And the unfortunate thing about this is you may be asymptomatic. The majority of people are asymptomatic when this whole process is going on. So it's very important to have to know you're at risk before this even happens. So let's talk about a little bit about epidemiology and risk factors. Well, I think we have to understand exactly what's going on globally and what's going on in the US to understand why it really matters. So globally, the prevalence is 30% of the global population. Well, there's 7 billion people in the world and growing. 30% of that 7 billion is 2 billion. So it's a very humongous number. And you may say, well, how can you estimate that? Well, let's take a look at the US population. We can do that, and there's been studies in other countries that have been able to extrapolate this data. The largest study to date is a study where they looked at a bunch of data from a big reference base. And our big reference bases in the US are the National Health System, which is the VA Medical Center, the NIH, the National Institute of Health, which has a robust data set, the ACCHA, which has a robust data set. And even regionally, we have data sets from New York City. And what they've seen in the data sets in the center is that 30% of the US population has it. So if the number of people in the US by population is 300 million, well, that's estimated to be 100 million people. So that's 1 in 3. If you have a family of 4, well, 4 people in your family, one of you may have ultimately MASLD or fatty liver. And so it's very important to recognize that this is and understand that this is a very under-recognized issue. The cost of the health system, well, all those people are having chronic comorbidities. Well, it leads to healthcare expenditure. And just thinking from that perspective, if you were to put it into dollars and cents, well, it's estimated to be more than 100 billion a year and growing as the population ages and as we get better at providing preventative treatments. Our major risk factors: obesity. Obesity is a huge risk factor in the United States. It's a huge risk factor and growing epidemic in children and adolescent and young adults. It's growing as the population gets older, as our foods become less and less refined. And so we can understand why obesity is the major problem and risk factor for developing MASLD. Insulin resistance, well, pre-diabetes and type 2 diabetes is the second biggest risk factor. How many patients have insulin resistance? Well, Have you ever checked a fasting glucose or for your annual well visit, and the only number that's in red from your blood work is the glucose level? Well, that means you may have impaired fasting glucose, and it's a clue for us and for yourself to think, hey, am I ahead of the curve? And I have to think about, is my insulin not working as it should in my body? Dyslipidemia, elevated triglycerides, low HDL is a big problem, and metabolic syndrome. Metabolic syndrome encompasses 5 different risk factors, and you need 3 of those risk factors. Well, we'll go over them. So one is BMI, and the BMI number is not your traditional BMI number. BMI, which we think of it as a general public, is obesity, which is more than 30. But in metabolic syndrome, it's more than 25. And it's subcategorized based on ethnicity. In Asians, in South Asians such as myself, it's more than 23. So I'm already at risk being a BMI of more than 23. Then there's waist. Let's say your BMI is normal, but your waist, you also have to look at waist circumference. So if you wear a size 38 pant, well, and you're a male, well, you're already meeting one of the risk factors for metabolic syndrome. In women, if you're a size 31-inch waist, well, you're already, and more, you're already meeting a risk factor. Triglycerides more than 150 is a risk factor. Being on lipid lowering therapy is a risk factor. Having a glucose that is abnormal, more than 100, more than 200 in a glucose tolerance test, or pre-diabetes, more than 5.7% is a risk factor. And having low HDL, so that quote unquote good cholesterol being low, less than 40 in men and less than 50 in women is an independent risk factor. So you need 3 of them to be at risk for metabolic syndrome. And then age and gender. We know that we start taking care of ourselves when our ages are above 40. When we're in our 20s and college age, when we're adolescents, the world is our oyster. We can eat anything we want and we bounce right back. When we're in our 30s, well, all of a sudden, once you hit 30, for some reason, you start getting aches and pains in your joints that you never had before. When you hit 35 to 40, well, why is my sugar level rising? Why is my cholesterol rising? You go for fancy tests such as mammograms, and you go for your pap smears. You go for your preventative task force exams such as colonoscopies and endoscopies, and you end up having all sorts of chronic diseases you didn't know about. Well, it makes sense that MASLD would show up in patients that are middle-aged. And men are affected more than women. Now we're finding that there's genetic variations as well. On the left upper side, there's an infographic just showing that the percentage is not just in the United States. It's truly a melting pot disease that encompasses the entire world. And so no one is immune from MASLD or MASH. I want to present this one slide because I think it's very important. I said obesity and type 2 diabetes are the highest risk factors, but up to 20% of individuals with quote unquote fatty liver disease are considered lean. So I want you to really put that into perspective. 20% of people we diagnose with MASLD are thin, but you can have type 2 diabetes and be thin. You can have metabolic syndrome and be thin. You can have genetic risk factors and be thin. So it's very important to know that just because you're not obese, that you're not immune to developing liver disease. Here's an important concept that I just want everyone to understand, and I put it in 2 variations, and I kind of took the right picture from Dr. Buchholz, who is a transplant hepatologist at New York Presbyterian, I believe. And in the left picture is a picture of the liver. So a healthy liver is in the top left, or a normal bucket. I told you just in the previous slides that 30% of the US population has steatotic liver disease that is underdiagnosed. So that is this picture here. Out of those 30%, or that bucket, the next bucket, between 5 and 20% of those people will end up developing MASH. Okay, so if you take one bucket, you pour a little out, you get the second bucket with MASLD. Well, 20% is a big number of the 100 million. That's still 20 million people will end up developing hepatitis, metabolic associated steatohepatitis. Out of that, 30% of them end up developing fibrosis. So that's still a very big population health number. Out of that, another 25 to 30% develop cirrhosis. So these are really, really, really big numbers, right? And you can imagine that the time frame from MASLD to cirrhosis is just accelerating. A lot of people are underdiagnosed. Here is a very important slide from a 2021 database looking at the United States liver transplantations, starting from 2002 to 2018. And the proportion of people that were listed for non-hepatocellular carcinoma were listed for liver transplant. And in this light green line, you can see that year after year, every 2 years, what is now the second most common cause of liver transplantation in the US? Well, it's metabolic associated steatohepatitis. The number one is alcohol, but the number two is MASLD leading to MASH. And so it's very important to know, and this is just growing. You can see that MASH is, if you extrapolate the data, is probably going to take over alcohol in the near future if it hasn't already. And so it's very important to know that the liver inflammation, and here I'm going to switch on my hat for the cardiovascular preventative cardiologist perspective, that liver inflammation can affect the heart. And it's more of the same of what we talked about, is that the pro-inflammatory markers, the same ones you find in the liver, are the same ones you find in the heart. The heart and liver are friends. And we have things called, we have the same molecules called IL-6 or interleukin-6. We have the same molecules called tumor necrosis factor or TNF alpha that accelerate atherosclerosis or accelerate plaque buildup in the arteries of the heart. Remember, I studied and I practiced cardiovascular medicine. Cardio meaning heart, vascular meaning plumbing, the plumbing of the entire body. So it's not just the heart. It can be the carotid arteries. It can be the peripheral arteries in the legs, in the arms, and in the general whole body. We have oxidative stress. So all that lipid buildup, all that accumulation of lipids, because the liver is not working efficiently. It's not able to break down all the lipids. It's just growing more and more cholesterol. Where does it release? It releases into the bloodstream, and all the oxidative stress molecules join their lipid friends, and then they damage the walls of the vessels, and that's how you get plaque accumulation. Well, we talked about insulin resistance. It leads to plaque formation in the walls, and any little plaque, we know for a fact, any little plaque can accelerate and accelerate and accelerate. Once you have small minimal plaque, it just accelerates over time if you don't do anything about it. And that acceleration is ultimately what leads to cardiovascular disease downstream. And then lastly, liver fibrosis. That liver fibrosis in itself can lead to increased cardiovascular events for all the other reasons that I talked about. So we connect it, and I've shown you here on this slide again that we have systemic inflammation, we have dysfunction of the endothelium, which is our vessel walls, and we have a big clinical overlap. Well, whenever you step into a cardiologist's office or your internist or family physician's office, what do they always harp on you about? Hey, I think you should lower your weight a little bit. I think you should eat a little cleaner. I think it's important to follow a exercise regimen. I think we have we have evidence of impaired sugar levels. We have evidence of high cholesterol. Your blood pressure is starting to rise. So let's work together. And in the next 1 to 3 months, come back to the office. I'm writing you an exercise prescription. I'm writing you a nutrition prescription. Let's work together and prove to me in the next 1 to 3 months that we can lower some of these risk factors. If we can't, we talk about the next screening tools, and we talk about medication therapy. And I'm sure every single person on the call has had that conversation with their family doctor and with their cardiologist, if not GI doctor or some sort of provider. And so, how do we screen for liver health, and how do we screen for cardiovascular health together with this MASLD? Well, we identify at-risk patients, and at-risk patients are anyone with chronic comorbidities. So anyone with type 2 diabetes, pre-diabetes, insulin resistance, anyone who's overweight or obese, anyone with genetic predisposition. So it's important. Does anyone in your family have any liver conditions? Anyone ever been diagnosed with fatty liver disease? Or anyone with metabolic syndrome? We talked about increased waist circumference and blood pressure, and we talked about triglycerides and insulin and sugar level. Then we can do a fancy calculator called the FIB4 calculator. And what that is we plug in your age, we plug in 2 liver values that we get on a regular liver test, and we plug in the platelet count, and it spits out a number. If your number is less than a certain threshold, well, then you're at a lower risk for developing MASLD. Can you still develop it? Yes. It is not 100% foolproof. None of our risk calculators are ever 100% foolproof, but it just quantifies your risk category. And if you're high risk, well, then we need to really get on board with a proper lifestyle intervention and medical intervention. If you're in the intermediate risk, well, more screening tests should be done. And those screening tests are ultrasounds. Those screening tests are something called FibroScan, which is the bottom right picture, which is a fancy ultrasound. None of this stuff is invasive. There's no biopsies being taken. It's all ultrasounds that you can get at many imaging centers out there. And all it's doing is you're putting a little bit of hopefully warm jelly. You're taking an ultrasound probe, and in 10 minutes, you're able to scan the liver and see, do you have architecture that's showing fat cell infiltration? Then we take a cardiovascular risk profile. We, Dr. Katz and I, as preventative cardiologists, clinical cardiologists, will talk to you about your liver profile. We'll talk to you about your blood pressure. We'll order a special scoring imaging called a calcium score, which is very important and can show us, is there any calcium built up on your heart vessels, your coronary arteries? We will stratify your risk based on risk calculators such as the PREVENT risk calculator, such as the Framingham risk calculator, which tells us in 10 years, what is your percentage risk that you will have a major adverse cardiovascular event. So we can literally spit out a number and say, hey, the proof is in the numbers. You are at an increased risk. Let's do something about it. And then we'll talk about early intervention strategies. So what are those intervention strategies? Lifestyle modification is first and foremost. Without caring about the biggest tool any provider can give you, any physician can give you, is to emphasize your own lifestyle tools that you have day in and day out, 24/7 at your disposal. What does that mean? Eating healthy, eating whole grains, lean proteins, fruits and vegetables. The more green and leafy, the better it is. Just trick yourself. Even if you don't like leafy green vegetables, trick yourself. Less processed foods, less canned goods, and absolutely limiting and eliminating high fructose foods altogether. We'll talk to you, and what you can do is physical activity. So we in the American College of Cardiology and the American Heart Association recommend 3 to 5 days a week for 30 to 50 minutes, you have moderate aerobic exercise. So if that means walking at a speed of 2 to 4 miles an hour in your neighborhood, and it's not just moseying around or very slow walking. It's a brisk pace, like pretend your dog is pulling you pace. That is what we want you to do. Pickleball, swimming, these are all great moderate aerobic exercises, and we want you to obtain at least 150 minutes per week. An added benefit is resistance training. So picking up 5-10 pound dumbbells and going through a set of 3 to 5 exercises 3 times a week is all we're asking for. So you can do that in the house. Let's say you can't afford dumbbells. Well, then you can take milk jugs, you can take water jugs, you can put a pillowcase and you can put books into it, and you can do exercises with those and do resistance training at home. We aim for a gradual weight loss. So we ask for 5 to 10% of total body weight over the next 3 to 6 months. Reduce your weight by 5 to 10%. So how much is that per week? Well, it's a half a pound to a pound per week. We're not asking you to lose 2 to 4 pounds, get on any celebrity Instagram diet. What we're asking for is gradual weight loss. Baby steps. Every half a pound counts. And then we ask for lowering your alcohol intake. Well, if you drink alcohol excessively, which we talked about, lower that amount 1 to 2 drinks every single day. If you drink 6 drinks a day, go to 3 drinks a day. If you can abstain completely, that's even better, but go to 3 drinks a day over the next month. Then the second month, go to 1 drink a day. So over time, slowly reduce that intake to very minimal, if none altogether, as alcohol can worsen your liver. Long-term therapies, well, now we're finding more and more medical therapies are being developed. So what do? Well, we want optimal glycemic control. There are certain drugs. The most foremost drug that goes hand in hand with obesity is our GLP-1s. So what are GLP-1s? Those are drugs that you've heard on the internet, such as Ozempic, such as Mounjaro, such as Zepbound, such as Wegovy. Well, these are actually studied and proven to be beneficial. There are caveats to these drugs. These medications are not for everyone. So you should really ask your provider if you even qualify for it. And if you do qualify, there is evidence that it does lower weight. It does lower the fat cells in the liver, and it does stabilize disease progression. We have new emerging therapies. There's a drug. This is a very tough name. I'm gonna butcher the name, but it's called Resdifra is the brand name, but Resmetirom is the generic name of it, or the unbranded name. And that is a drug that was just released to market last year, which is used in stage 2 and 3 MASH fibrosis, and it actually reduces the fibrosis burden. It works on the liver in a very interesting pathway, but long story short, it stabilizes and reduces fibrosis in the liver, and it's a game changer. Before that, we did not have any drugs that could do that, and now finally we have a drug that does that. Yes, there are side effects with that drug, so do ask your hepatologist before you even consider that drug. And if you do qualify, let's say you have MASH fibrosis, if you do qualify for that drug, please see a preventative cardiologist, because some of the cardiac medications, such as some of the statins we use or some of the antiplatelet agents we use, will have to be tailored, or antiarrhythmics, or so drugs that we use will have to be tailored because you're on that medication. See your hepatologist routinely and get regular cardiac follow-ups. A routine question I get, well, I have high liver enzymes, or I may have normal liver enzymes, but I have fatty liver disease, or I have MASH. I have MASLD, or I have MASH, and I have high liver enzymes. I have high cholesterol. Can I take a statin? And the answer is a resounding yes, you can. Statins have been proven in multiple, what they call meta-analysis, which are taking a bunch of randomized controlled trials and a bunch of trials, and it composites it all into one big trial and it studies all the findings, and it's been shown that statins are safe for your liver. and they do have benefit in your portal circulation, which is the circulation of your liver, in reducing a lot of the atherosclerotic burden, the fat concentration, and reducing the pressures. So statins are very safe. When you get to cirrhosis, that requires an expert preventative cardiologist, a very good cardiologist that knows how to deal with statin therapies. And there are certain statins that you can take even if you have liver cirrhosis, certain grades of liver cirrhosis, not the advanced grades. So please speak with your preventative cardiologist. So I just want to summarize very quickly. The liver and heart connection is very real. We are friends. If one organ, the heart is the motor of the body. It is strictly the motor of the body. Anything that is stressed in the body stresses out the heart. So if the liver is stressed, the heart will become stressed. And so MASLD, metabolic associated steatotic liver disease, or MASH, metabolic associated steatohepatitis, is very closely linked to increased cardiovascular risk, and it's an important risk enhancer. Shared risk factors: we share type 2 diabetes, we share hyperlipidemia or high cholesterol, high triglycerides, we share obesity. Between MASLD and liver disease, and between our cardiovascular disease, early detection is key. Ask your family provider, your family physician, ask your cardiologist if you have one, ask your gastroenterologist, endocrinologist, any internist. Hey, am I at risk for MASLD or MASH? And if I'm at risk, what can we do about it? And last but not least, the tools that we have start first and foremost with yourself, the patient. It's completely free. And it's something you can do on a day-to-day basis. So right now, if you're only walking 1,000 steps a day on your Fitbit or Apple Watch or your smartphone, and the health app only says you're walking 1,000 steps a day, well, go and walk 5,000, 6,000, 7,000, 8,000 steps a day. Any increase amount counts, up to 150 minutes of moderate activity. If you're eating a lot of fatty foods, restaurant foods, fast foods, well, say, hey, I'm not going to eat out every single day. I'm going to try to limit it to once a week, or I'm going to try to limit it to once a month, and the rest of the time meal prep and cook at home. Whole food is important. Mediterranean diet is very important. And last but not least, just be aware of what's going on. It may not be you that is affected with the disease, but 1 in 3 people in the United States are. So look to your loved ones, look to your friends that you truly care about, your family members, and say, hey, have you gotten your annual well visit this year? If you haven't, please go see a physician, please go see a provider, and do get checked out, because it's a very underdiagnosed disease. Here are some questions. I'll leave this up, and I thank you very much for listening to me for the last 40 or so minutes in this webinar.
Fantastic. Thank you so much, Tappan. That was a wonderful presentation. I know I've learned so much. I hope everyone on the webinar has. And now we are all experts in MASLD, as I said when we started. I don't see any questions in the chat yet. If anyone has a question or a comment, please add that in. But until we have some, I certainly have a bunch.
Okay.
Okay. Well, my first question to you is, when we talk about coronary artery disease and cholesterol plaque in the heart arteries, we always say that we have to practice primary or even primordial prevention, like stopping this from ever happening at all. And we've known from autopsy studies on young people who died tragically that the cholesterol in a heart artery can start in infancy sometimes, which is crazy, but certainly by, adolescents, 16-year-olds who were healthy and died were found to have fatty streaks. And I'm just wondering if there's a parallel. Like, I know you said that this really is diagnosed fatty liver in middle-aged people. Is there any studies or data that shows that steatosis starts earlier? Do we know about
Yeah,
that?
so that's a great question, Dr. Katz, and I bring it back to this slide, the Fib4, and I bring it back to this slide because the age cutoff for when they created this calculation score was 40 and above. So 40 years old up to 65 years old, and that's truly where they created the age bracket and cutoff. Luckily for us, we have now been able, with the use and the implementation of electronic medical health records, we've been able to really look and take a deep dive into age ranges that are above 65 and age ranges that are below 40. So there are actual values for people that are below 40 and below 35 that are out there, which show that you're at a low or increased risk. And so that value changes. And that value, here you'll see the low risk is 1.3, but in that value, the low risk is less than 2. So it's actually a higher amount. And so just extrapolating that into not so much infancy, but into teenagers and young adults, well, we have seen in the medical profession that people are developing and presenting to our offices with more, or to the hospitals with earlier diabetes, with earlier obesity, with earlier with earlier metabolic syndrome, and we're becoming very keen and perceptive in saying, oh wow, this 13-year-old or this 14-year-old actually has this condition. And so when you take a look at the data, yes, now there's actual pediatric hepatologists and pediatric cardiologists that are looking into this and showing that there is fatty infiltration in the liver. Now, is it to the extent of adults? Not to that extent, unless there's a genetic predisposition. And the reason being is because adults, for for lack of better saying it, well, a child, a teenager shouldn't be consuming any sort of alcohol. Well, an adult, chances are they've consumed one or two drinks on occasion, and so that accelerates the risk. So yes, there is some data emerging, and it mainly deals with genetics, but it also deals with the chronic comorbid conditions that we see, that are affecting our adolescents and
Yeah.
teenagers.
Thank you. And there are a couple of questions in the chat now, and that was a good segue to this one. This question is, aside from the contributing factors such as obesity, type 2 diabetes, poor diet, alcohol consumption, are there any genetic predispositions that can also increase susceptibility to MASLD?
Yeah, so that's a great question, thank you, Jay. It's nice to virtually see from you again. Jay and I were friends from Pennsylvania back in our my training days. So nice to hear from you again. And so there are genetic mutations that we are now seeing that are very susceptible to that people do have a predisposition of developing MASLD and MASH. And so one of the genes, there's quite a few. There's 5 to 10 that have been sorted, but one of them, it starts with a P, and there's a intricate long name, but there's a hyphenated name too. But it shows that this certain genome or genetic allele, if you have that and it's penetrant, which means it shows up in you, and you have the allele and it does show disease, well, that's associated more with developing fibrosis and then leading to cirrhosis. So it's actually very important. We're noticing that genomic studies, a lot of people that do have MASLD and MASH are being screened genetically, and we're finding that they do have a genetic predisposition altogether. Matter of fact, and I'll take you even one step further. There are studies which are very interesting, showing gut microbiome. What you have in your gut bacteria can lead to the development of MASLD or MASH or liver disease. And so not all gut bacteria, we all have bacteria in our gut. it's thought to be the second brain of our body. We have our brain in our head, and we have the brain in our gut. And what we're finding is that if there's an imbalance of certain bacteria, well, that imbalance can lead to disease processes. And one of the disease that they're finding, if people have more E. coli, per se, they may be at higher risk for developing MASLD or MASH. And so it's a very interesting and rapidly growing space that is being explored in the world of gastroenterology.
Great. And along those lines of genetics, I know there were more questions, but I just want to ask you this one. Along the line of genetics, like when we identify someone who has a high lipoprotein little a, let's say, we then do cascade screening. We ask the patients who have this to then ask their first degree relatives, like their siblings and their children, to be screened for this blood test. Is that the case if someone has a genetic abnormality that leads to MASLD or MASH? Then you
I
then do cascade screening?
I think it's important. I think that's a great question, and I think that's important. What we're developing, what we're talking about, is precision medicine. And so when you as the proband or the patient develop a disease, are my loved ones and my family members, my first degree relatives, so my immediate family, my parents or my siblings or my offspring, my children, are they at risk? And what we're finding in the cardiovascular world, as you mentioned, is that yes, they are at risk, and we have genes that correlate. We're also finding that in this space as well, that if you have fibrosis or you have and you screen gene positive, well, we should look after your family members and see if they're at risk as well. The important thing to know, and that becomes even more important in if someone does not drink any alcohol, they develop cirrhosis at an early age, at 40, 45, 50 years old. Well, those are the patients I would definitely screen, because you're young, you're too young to have this disease, right? And so we should be screening and testing these people and seeing if their loved ones don't have this, and can we prevent it in their loved ones
Right, right. We can start, modifying risk factors earlier.
early.
There
Yep.
is another question here in the chat. Are there any symptoms that are first noticed?
That's a great question. And all the experts that you talk to, they will say you're completely asymptomatic. It's like, how I can draw the parallel is, it's like blood pressure. It's like sugar level. You're pre-diabetic until you're diabetic. You have elevated blood pressure until you're given a formal title as you're hypertensive. So and until something happens, well, oh, I can't, my vision is getting worse. You'll hear symptoms like this: I'm feeling a headache, or my vision is getting a little worse. I'm getting like double vision more so than usual, or my fingertips and my toes, like I'm not feeling sensation in my fingertips or toes. Well, those are all triggers. Or I'm feeling more fatigued than usual. Those are all triggers, and those are all warning signs. Well, those warning signs didn't happen until it was 10, 20 years too late. And so the problem is that a lot of patients are asymptomatic. And so that's where it becomes very important that if you do have one of these risk factors, that we screen you for liver disease and MASLD and steatotic liver disease, because we can prevent you from even developing fibrosis or cirrhosis way earlier on, so you don't become a statistic. That's what we're trying to prevent.
Sure. Another question is this: if successfully treated for hypertension and prediabetes, how does one check for liver issues? Ultrasound was mentioned, but who does that?
Your primary care provider, your family doctor, can order the FibroScan or the ultrasound, the liver ultrasound. Any imaging center can do a liver ultrasound. More and more imaging centers, because liver transplants and hepatology is a growing field, and more people understand the need for liver experts. More and more people understand the need for preventative cardiologists, such as ourselves. Well, a lot of hospital systems and a lot of imaging centers are doing fibroscans because it's simply an ultrasound. It's a non-invasive test that a lot of echosonographers can easily learn. And with the advent of AI technology, all you have to do is put the probe, find the liver, and the AI does the rest by checking various parameters. And so I would say it's growing in any imaging center. Dedicated imaging center likely has definitely the liver ultrasound. Not only liver ultrasound, but the fibroscan. If you want to take it one step further, then you can go for a liver MRI. That MRI machines are in almost every major hospital system or hospital in the country. And so the radiologist will be able to read a liver MRI if worse comes to worse, if you can't find someone that can do a liver ultrasound or fibroscan.
So is the FibroScan more sensitive than the liver ultrasound? Like, can we miss it
Yes,
just by doing an ultrasound?
yes, it is. FibroScan is more sensitive than the liver ultrasound. It spits out two specific values, one which takes a look at the fibrosis number and one which takes a look at the amount of fat accumulation, where a liver ultrasound in itself just shows you the architecture. And you give a very educated estimation of what the percentage is.
And is this something that's usually covered by insurance? Like, is it something that's readily accessible to everyone on this webinar?
Yeah, yes, it is more and more. As long as you are have the risk factors, it is becoming very insurance favorable because we're ultimately trying to prevent fibrosis and transplants. And so, so if we can prevent it, those are very high value based tests and high value for not only the patient but the payer, which is the insurance companies. And so they do encourage and approve ultrasounds of the liver
Mhm.
and fibroscans.
So we're almost at time, but I do have another question, because I think we've exhausted the ones in the chat. So let's say someone has MASLD or MASH, one of the two, and hops on board and follows the Life Simple 8 that the AHA has told us to follow, diet, exercise, sleep, the whole thing, and does well, or gets on a GLP-1 receptor agonist and loses weight. Is there such a thing as regression of steatohepatitis, of steatosis?
Yes, what we found is that patients that lose the weight that can really treat their risk factors, they do have regression of the fat cells. So it's a beautiful thing. The body can reverse fatty liver or steatosis, and the body can reverse a few of the early stages of fibrosis even. And so it's a remarkable thing, and that's why it's so key and important to identify it early and to treat it early.
So it all comes back to healthy living. What's good for
Yeah,
the heart is good for the liver, is good for the brain, is good for the soul, everything. So I
absolutely,
think we're almost
absolutely.
at 8. If there are no other questions, I think we'll let everyone go have a really heart healthy dinner, if you haven't already, full of leafy greens, right? And maybe not
Yes,
we'll leave the glass of alcohol, we won't have that tonight. But this has been
yes.
absolutely wonderful, Dr. Bush. Thank you so much for presenting. And thank you everyone who joined the webinar, and we hope to see you at a future one.
Thank you so
Yeah,
much.
thank you, everyone. And for those of you who might have missed any portion of this presentation, it is recorded. And so we'll be sending out the link to everyone to have so you can watch it at a future date as well. Thank you.
Good night.
Good night.
Have a good night.